Hello students, this is Dr. Ways and welcome to your lecture on the lower limb overview. Alright, so even though we've covered the pelvis and the bones associated with it, the pelvis is still part of the lower limb because one, the bones of the lower limb directly attach to the pelvis, and the muscles that are involved in hip movements go between the bones of the pelvis and the bones of the lower limb, as well as nerves and blood vessels. So counting the hip bone in the lower limb is something that will include and go into a little more detail about this, how specifically it interacts with the lower limb as opposed to the organs that are contained within it. So keep in mind that when we're talking about the lower limb and the bones of the hip, we're talking about the coxal bones as well as the sacrum and to a lesser degree the coccyx. Then we have the femur right here, the patella, also known as your kneecap, the tibia, the fibula, then all of your tarsal bones, metatarsals, and pedal phalanges. Alright, and the way we're going to divide this up is into regions, since this is regional anatomy. So we'll start with your gluteal region, and then do each section of the leg in terms of compartments. So we have the anterior thigh compartment, the posterior thigh compartment, the leg, which has compartments as well, and then the foot and ankle. And then after that, we're going to go into the knee joint and the ankle joint more specifically and talk about them. And then we'll talk at the end about all the muscles involved with movements of the lower limb. So the bones of the lower limb are connected to the axial skeleton or the trunk by a girdle, and specifically since we're here in the pelvis, it would be known as the pelvic girdle. And what the pelvic girdle consists of are your, generally speaking, your coxal bones right here, which would consist of the ilium, the ischium, and pubis right here. Your sacrum, which is right here, and the joints that hold them together. So here you would have the pubic symphysis right here holding together the two pubic regions of the coxal bones, and the sacroiliac joints here between the ilium of the coxal bone and the sacrum. Some points to be aware of as they mark borders or landmarks that can be palpated. Your posterior superior iliac spine, which is at the posterior border of your iliac crest, and at the anterior border you have the anterior superior iliac spine, or ASIS, and this would be PSIS. The ASIS in particular is a landmark that can be palpated and often used to identify other specific regions. Remember, we talked about the abdominal region. The ASIS is a landmark between the umbilical region where we can find McBurney's point. All right, so that is one of the ways in which you can use that particular landmark. Then we have the inguinal ligament right here that goes between the anterior superior iliac spine and the pubic tubercle right here by the symphysis pubis. All right, so as we mentioned before, the coxal bones, or the Coxae, plural, or Coxa, singular, are located right here, and everything that is colored in gray are the specific terms that I would like you to know, and you will have to identify in the lab. So I'm not going to go through them here in lecture because you'll be able to see all these parts in lab and find them yourselves in lab, but I do want to point out specifically that when you are looking at these bones, they are twisted, and so finding orientation for them can be a little bit difficult. So in order to know what you're looking at, the anterior part of the ilium is always going to be to a point right there at the anterior superior iliac spine, and in line with that is going to be the pubic tubercle, which also comes to a point. All right, so anything that is coming to a point is going to be the anterior. And then you notice the back, it's kind of rounded. So the posterior superior iliac spine is kind of a rounded process, and the ischium is also a rounded process. So you'll see the points in the front, rounded processes in the back. All right, and this is going to be the medial surface. How do we know that? Because the pubic bone is coming towards you in this direction. If we flip it around to the other side, we're looking at the lateral surface right here. They call this the gluteal surface because that is where your gluteal muscles will attach to. All right, and again, pointy, pointy, so you know that's anterior, round, round, so you know that is posterior. And then this obturator foramen right here, under normal physiological conditions, will be covered with a fibrous membrane with a small hole called the obturator canal for blood vessels to go through and nerves. So keep in mind that, you know, when we're looking at the bones, we're going to see a big hole where the obturator foramen is, but that hole physiologically is going to be filled in by connective tissue as well as blood vessels and nerves running back and forth. All right, to continue with the coxal bones, we just want to point out that the coxal bones are actually made of 3 separate bones that have been fused together, and those bones include the ilium, which is this major part right here, and here are the dividing lines. The ischium, which we've said already was in the posterior part of the coxal bone, right here. So all this blue would be the ischium. And then the pubis, which would be that pointy region in the front that forms a joint with the other pubis bone from the other side to make the pubic symphysis. And of course this area right here where you have the lunate surface of the acetabulum or the acetabular fossa is where the femur, the head of the femur, would fit in and form a ball and socket joint. Okay, so again, we're not going to cover the specific names. You can see them here listed in the gray, the ones that you're expected to know. But what I do want to point out is that right here at the articular surface for the sacrum, which is also known as the auricular surface or ear-like surface because of its shape, that is where the sacrum will make an articulation with the coxal bone on this side, make the articulation on this side, and on both sides you would call that the sacroiliac joint. All right, so the auricular surface of the ilium would make a joint with the ala of the sacrum. All right, and this right here would be the anterior portion of the sacrum, and that would always be pointing towards the pubic tubercle from the back. Right, so there would be the anterior surface. And then of course the sacral promontory in this area right here that looks like the body of a vertebrae would articulate with the body of the 5th lumbar vertebrae. And then of course the coccyx down here would fit in with the 5th sacral vertebrae, because all of these used to be vertebrae that have fused together and then form the tailbone there. If you were to see a skeleton, like archaeological dig, things like that, or like in the laboratory, look at the skeleton, you can tell which is male or female based on the what the pelvis looks like. So A here we have the female pelvis, and B here we have the male pelvis. And the first thing you should notice is that the female pelvis is much wider. All right, so it's much broader. The ilium, the ilia, are flared out a little bit. The pelvic inlet has more of a round feature to it as opposed to a heart-shaped pelvic inlet, which is more narrow. And then if you look at the angle between the ischiopubal rami on either side. In males, you have a more acute 50 to 60 degree angle, but in females, you have a wider angle, 80 to 85 degrees. And of course, the reason why you have these differences is that a female, when she gets to reproductive age, if she does indeed become pregnant, this space allows for the growth and development of the fetus and the uterus that the fetus is within, as well as a wider pelvic inlet, thus a wider pelvic outlet, that the fetus, that the baby can be born through. All right. If we were to look at these at a slightly different angle, we'd also notice that the sacrum here and the coccyx of the female are more pointed posteriorly, whereas the male, they're more pointed anteriorly. Again, to give more room and space for the birthing process in females, and males aren't going to generally need that. All right, deep veins in the lower limb are going to course with arteries that have the same name. So if you have the common iliac vein right here, that is going to course with the common iliac artery. And then of course you have the external iliac vein and the internal iliac vein, which would course with the external iliac and internal iliac arteries. And then those are going to split off into your inferior and superior gluteal veins, and we talked about those in a previous lecture. Obturator vein and femoral vein. So all of these are what we would consider deep veins. And again, the deep veins specifically are going to run with and be named according to the arteries that they run with. And of course, they drain into the inferior vena cava ultimately. Distal to the knee, however, what you'll see is that deep veins tend to be paired with each other, and I think we're going to show that at a later time. And that arrangement is known as vena comitantes. All right, so they're paired, they're commingling with each other. Superficial veins, then, here we would have the anterior view and the posterior view. So they will originate in the foot and then course upward through the subcutaneous tissue, and then they will terminate, they'll end once they join with deep veins, and they'll join with the deep veins further up. So a couple of the key veins that you should be familiar with, at least at this general overview level at this point, would be the great saphenous vein. And the great saphenous vein happens to be the longest vein in the body. So it's going to go all the way from the foot upward, and actually you see that right here coursing along the medial side of the leg. And it's going to enter into the pelvic cavity through this little hole we see in fascia right here, right beneath the inguinal ligament. And we'll talk about what that is and the importance of it later on. The other vein is the small saphenous vein, and you notice that that is running more laterally along the leg right here, and that is going to course up to about the popliteal region, where it will then join the popliteal vein and then continue heading upwards towards the trunk. All right, the next bone that you'll find in the lower limb would be the femur. And again, we're not going to go through all the different parts. They are outlined for you here, and if they are not all here on this particular slide that I'm talking about, you will find them in your PowerPoint slide that your static PowerPoint slide that you're taking notes on. But what I do want to point out that you will be doing in lab is we will have a disarticulated skeleton, and it would be your job to figure out which is the left femur and which is the right femur. And so a good way to identify that is that when you're looking at this, the outside here, that is your greater trochanter. All right, and you can feel that on your hip. It's that bony part of your hip that you usually use to like close doors and things like that. So that will be on the outside. The head will be always pointing medial, going into that acetabulum or acetabular fossa. And then down here you have the lesser trochanter, all right, this smaller bump in the bone that's between the greater trochanter and the head of the femur, and that will always be located posteriorly. So what we're looking at here in this particular picture is a right femur. So again, we would call this the proximal end of the femur because it's oriented closer to the trunk of the body. So in this panned out view where you can see the entirety of the femur, this would be proximal, this would be distal, and of course down at the distal end, these are parts of the bone that would articulate with the tibia below it and form the majority of the knee joint. And one thing that can be confusing here and to remember is you have these epicondyles on either side, the medial epicondyle and the lateral epicondyle. And so how do you know which is medial and lateral? Again, if you take this condyle and go upward, or go superiorly, you see that it is on the same side as the head of the femur. And if you know the head of the femur is always medial, then this has to be the medial epicondyle. And if you take the lateral and go up and hit the greater trochanter, and you know that the greater trochanter is always lateral, then you know that's a lateral epicondyle. Right, another way to look at this is indicated by this small picture right here. If you look at a cross section of the bone, you notice that the anterior aspect of the diaphysis of the bone is flat, whereas the posterior surface of the diaphysis is comes at more of a point. So, you know, if you are, again, having difficulty and you don't remember that the lesser tubercle is on the posterior surface, then the fact that the posterior surface comes to a point and the anterior surface is more is flatter, then that's another way to gauge orientation. As for the patella, which is sitting in front of the knee joint and would round out the rest of the knee joint that is made between the femur and the tibia, is held in place by tendons coming from the quadricep muscles and ligament that would attach to the tibia below it. All right, and it kind of has an arrow shape. The apex, the point, would be facing downward, the base would be facing upward. So similar to what we see with the heart, the base is at the top and the apex is at the bottom. And the front generally has or the anterior surface generally has a rough surface to it, and the posterior surface has some cartilage, so it's going to be a smoother surface so it can make an articulation. All right, the next bone going down is the tibia, and the proximal portion of the tibia has a lateral condyle and a medial condyle that the femur will sit directly on and make a joint, a hinge joint with the tibia. In front you have this tibial tuberosity, and you can actually feel the tibial tuberosity in yourself if you bend your leg and go below the knee joint and there's that bump. That would be the tibial tuberosity. And to tell front from back, notice here that the anterior border of the tibia comes to a point, and that's the exact opposite of what you see with the femur. Whereas the femur, the anterior portion was flat, and the tibia, the anterior portion comes to a point, whereas the posterior surface is a little more flat or rounded, if you're looking at the cross section. All right, looking at the whole tibia, we'll go down to the distal end here, and you see that there's a flat part and then a point. All right, that point is known as your medial malleolus. And so if you're looking at the tibia and you go to the point, that's going to be the medial malleolus, so that when you go up and you're wondering which condyle this is, if it's on the same side as the medial malleolus, then it's got to be the medial condyle. That would make the other side the lateral condyle. And you can feel this medial malleolus. That would make the bump on the medial portion of your ankle, the bump that you can palpate. And then the other bone that sits with the tibia would be the fibula. And don't get these mixed up. I've had students call them the tibula and the fibia. That just tells me you don't know them. So tibia, fibula. All right, so just of interest, tibia actually means flute. Fibula actually means a pin, like a clasping pin, because that's what it reminded anatomists of when they first identified and named these structures. So the fibula is going to be a much smaller bone. It's always going to be located laterally, not medially. So your fibula is on the lateral aspect of your lower leg. And the one end comes down to a point, and you can palpate that on the lateral portion of your ankle. That's known as the lateral malleolus. All right, so you have the medial malleolus on the tibia, the lateral malleolus on the fibula. And although it's not shown here, the tibia and fibula are connected to each other by what we call an interosseous membrane. So there will be a membrane between those two that will allow them to be connected to each other so they don't move too much independently of one another. All right, again, keeping with the same theme, these are the bones of the ankle and the foot, and we'll talk about generalities, but I'm not going to give you, go through all of the names. So tarsals are going to be specifically the bones of your ankles, so that would be all of these right here, or all the ones that you see in color on the left picture. Those would be your tarsals. And a way to remember them from the carpals, which are going to be in your hand, is you walk on tar, like pavement. So you walk on tar with your tarsals, and you drive a car with your carpals, because those would be in your wrist. So just stupid little thing to help remember, but those stupid little things are often what help you through stressful times. So use those. This would be the inferior portion of the foot. All right, so you're looking at what we call the plantar view. This would be the superior view of the foot, what you would call dorsal. All right, and the way the ankle works here is you have this talus bone, which is one of your larger tarsal bones, and notice it has an articular surface. So here your tibia would sit right on this surface, and here would be your medial malleolus, and then on this side would be your fibula and lateral malleolus. All right, and then of course you have your calcaneus, which would form your heel, and then you have these bones of these smaller bones of the tarsals. Moving out to the metatarsals. All right, the metatarsals, people confuse this a lot. The metatarsals, even though they have space in between them, you will still have solid skin up to this point. All right, solid skin, so you won't see any space between them. And then once you get to your pedal phalanges, and I like to call them pedal phalanges versus manual phalanges, so that you're talking about different phalanges, because you have phalanges which are your toes and phalanges which are your fingers. So pedal phalanges, you pedal with your feet. This is where you would see the separation, all right, of the skin with the phalanges. And notice that the phalanges, they are numbered starting with the great toe, 1, 2, 3, 4, 5, and you're going to find that your manual phalanges are numbered the same way. The way that the phalanges are named in terms of the bones that are within them are proximal, distal, proximal, middle, distal, proximal, middle, distal phalanges of the third digit, proximal, middle, distal, proximal, middle, distal. And then the joints between them are also going to be important. This is going to come up in your physical exam lab. They're going to be referred to as our PIP and our DIP. And what that stands for is our proximal interphalangeal joint and our distal interphalangeal joint. So proximal joint between two phalanges and distal joint between two phalanges. And so that will come up in physical exam lab, and you'll be assessing those in both the hands and the feet. One thing I was telling you, I want to go back and kind of correct myself. Looking at this picture here, you have proximal phalanx 5, middle phalanx 5, distal phalanx 5. I think I numbered them a little bit differently earlier. I say proximal, middle, distal phalanx of the third digit, but you can also call them proximal phalanx 5, middle phalanx 5, distal phalanx 5. Okay, as long as you know what you're talking about and you get that across clear to whoever is evaluating you on this, then either will work. And another thing to keep in mind is that the great toe, again, always on the medial side. Fifth toe, always on the lateral side. All right, as far as lower limb lymphatics, they are going to follow along circulatory paths and going to have lymph nodes in key places where you will have generally potential sites of penetration for microorganisms. So that would include your knee joint here, the popliteal nodes in the knee, as well as your inguinal nodes, your superficial inguinal nodes here, and superficial inguinal nodes here, which include your superior, which run along the inguinal ligament, and your inferior, which run more medial. And of course, these sets right here are going to be your palpable lymph nodes that you should be able to identify in physical exam lab. All right, the next bone is the sacrum. All right, the sacrum is, actually it's called the sacrum because it was once referred to as a sacred bone. We talked a lot about this already. You have the ala, which form the sacroiliac joint with the ilium of the coxal bone. And at the superior end and at the inferior end, you have the coccyx that would be attached. And then one important thing to take note of is you have this sacral canal and the sacral hiatus through which spinal nerves are going to run through and get to where they need to go and have that bony protection of the sacral canal. All right, as far as surface anatomy goes, remember I told you that your greater trochanter is going to be right here, that hard spot on your hip that you usually use to bump against things, to close doors, for example, when your hands are full. And then if you go just medial to that, you'll run right into your sciatic nerve. Okay, so your sciatic nerve is about midway between that greater trochanter and the intergluteal cleft. All right, and then on the underside that forms what you would call the bottom of your cheeks, those would be called the gluteal folds. All right, so intergluteal cleft, gluteal folds. And of course, just looking here to identify, this would be your piriformis muscle. Clinically relevant, if you go to the dorsolateral aspect of the leg and thigh, what you can do is divide it into quadrants. So this horizontal line between the ilium and the ischium and the pubis, and then this vertical line that runs from the middle of the iliac crest down to the femur at an angle into quadrants. So you have your upper lateral, upper medial, lower lateral, lower medial. And the reason why I mention this is that this spot right here in the upper lateral quadrant is a safe injection site for IM injections. All right, usually you hear about people doing IM injections right here, and I've even done some IM injections right in that area. But when you do that, you run the risk of hitting the sciatic nerve, depending upon the size of your needle. So what's recommended now is that you do it up here in the what we call the ventral gluteal region. Safe site for IM injections. I also want to point out that the ischial tuberosity right here, so this would be the back side of your ischium, that rounded part that we talked about that lets you know it's the posterior part. When this person sits down, what they're sitting down on is the ischial tuberosity. All right, so just to give you kind of an idea surface-wise of where that bone is going to be located. And when my kids sit on me and I say they have a bony butt, what I'm talking about is their ischial tuberosity. All right, another important part of your surface anatomy is going to be the femoral triangle. And the femoral triangle is, the borders of it start at your pubic symphysis right here and run along your inguinal ligament to the anterior superior iliac spine. They're going to run down the sartorius muscle and then back up along the adductor longus muscle. All right, so all of that would be your femoral triangle. And if you look at it, what you see in a femoral triangle is your nerve, artery, vein, lymphatics. Nerve, artery, vein, lymphatics from lateral to medial. All right, and if it helps you to remember, that kind of looks like navel. So navel from lateral to medium. Nerve, femoral artery, femoral vein, and then your lymphatics in the femoral triangle. All right, surface anatomy of the knee. Of course, most people know where their patella is. That's a little bit bigger than what it should be. Then you have your patellar ligament, and then you have your tibial tuberosity right here. We talked about that earlier. If you bend your knee and feel that bump below your kneecap, below your patella or inferior to your patella, that would be your tibial tuberosity. And usually you can see the muscles coming out with your vastus lateralis and vastus medialis. In the back of your knee, you have this region called your popliteal fossa, and that is just a potential region in the back of your knee where there's some space, and you have blood vessels and nerves that run through there, and we'll talk later about how to remember those as well. So that's going to be your popliteal fossa in your popliteal region. All right, popliteal refers to the back of your knee. And then from the lateral aspect, what you see right here is your iliotibial tract, also known as your IT band, which is a band of connective tissue between your gluteus maximus and what we call our tensor fascia latae, which of course would be a hip flexor, and this would be a hip extender. And then one more thing to point out right here, and we pointed it out over here as well, would be your patellar ligament. That is a ligament when your patient is sitting on the table. You hit that ligament to elicit the knee jerk response, the knee jerk reflex. So it's this patellar ligament that you want to isolate, pound on in the right spot at a hard enough to make sure that it sends the reflex response to the spinal cord, and then it allows your quadriceps to kick the lower leg outward.